Sir, your voice is not.
Okay, okay. Sorry. Okay. So if you take your is it audible now? I think so audible. Okay. So audible, I think so now. Yes. Okay. Sorry. The so if you take any neurological case, you are going to present the diagnosis like the side of hemiplegia, okay, facial nerve palsy. And if you take the facial nerve palsy, if you take the facial nerve representation is like this, okay. So if you take the opposite side, is going to give supply like this, okay, supply like this, okay, which is going to be supplying the both part of the nucleus, and from the same side you are going to get the supply, okay. And this upper part is going to supply the upper part of the face. And if you take the lower part is going to supply the lower part of the face, okay, lower part of the face, okay. So now your patient is going to have a lesion, okay, and if the lesion is below the level of nucleus, then the patient is going to have ipsilateral element type of facial nerve palsy, where it is going to be involving the whole face. Whereas whenever the patient is having lesion here, okay, it is going to involve as human type of facial nerve palsy, where the patient is going to have contralateral. Okay, if you see this side, okay, the lesion is this side, but the patient is having facial nerve this side. Okay, and if you see here, the lower part of the face is involved, upper part spat. Okay, upper part is spat. Okay, so this is going to be very important thing in your examination. Okay, examination. So this is very important. Okay, so patient having mid-sided hemiplegia, human facial nerve palsy, okay, lesion, okay, whenever there is a lesion in your UG level, the lesion should be at the level of internal capsule, involving which territory? And usually it is going to be MCA territory, okay, due to thrombosis, embolism, and hemorrhage. Okay, thrombolism and embolism is going to cause infarct, okay, and hemorrhage is going to cause hemorrhagic stroke, okay, hemorrhagic stroke, okay. This is how you will make a diagnosis, okay, this is how you will make a diagnosis. And when you make a diagnosis, which territory is getting involved, that is very important. For this we have an important thing called circle of Willis. So imagine this as a circle of Willis. This is the internal carotid artery, this is the anterior cerebral artery, this is the posterior cerebral artery, this is vertebral artery, this is the basilar artery. Basilar artery. Okay. Now I'm going to impose the brain here. Brain here. Okay. And I overimpose the brain here. This forms the ACA territory. This forms the MCA territory. And this forms the PCA territory. Okay, PCA territory. Right? And this circulation is called as anterior circulation stroke. And this part is called as posterior circulation stroke. Okay. This is called anterior circulation stroke. This is called as posterior circulation stroke. Okay. Now, if you superimpose here something called inverted homunculus, Okay, if a patient has lower limb involvement, okay, lower limb involvement mean which artery you will put here? Lower limb involvement means which artery you're going to put here? When a patient presents with lower limb involvement predominantly, which artery you're going to? ACA artery. Whenever a patient has predominantly hand and face involvement, faciobrachial monoplegia, faciobrachial monoplegia, it is going to be MCA territory. Whenever a patient has difficulty in swallowing, okay, difficulty in swallowing, okay, dysarthria, dysphagia, dysphonia, then which artery? It is going to be more of a PCA territory. Okay, now all the fibers are going to start from here. All the fibers are going to start from here, from ACA territory, from MCA territory, from these territories. Okay, all these fibers are going to converge in a point called internal capsule. Okay, and this internal capsule is supplied by the internal carotid artery, and from internal carotid artery we have MCA. From MCA we have a branch called lenticulostriate branch. So whenever there is a lesion at your internal capsule, it is going to be the lenticulostriate branch of MCA which is involved. A lenticulostriate branch of MCA is going to get involved. It can be involved due to a thrombosis, okay, thrombosis, embolism, or due to a hemorrhage. Okay, whenever it is due to thrombosis and embolism, it is going to result in infarct. Which is going to result in infarct. Okay, so this is how you will make a diagnosis in a CNS case. Okay, that is very, very important thing. Okay, this is how you will make a diagnosis in a CNS case. Okay, so now coming to the examination part. Okay, whenever you have any examination in CNS case, okay, so you are going to have higher mental function, consciousness, orientation, memory, intelligence, speech, handedness, very, very important. Okay, very, very important. And emotion. Okay, so consciousness. Okay, so higher mental function is again checked by uh, different kind of things like MMSC scale, okay, where memory is also checked and higher mental function is also checked. Okay, then next is consciousness. Okay, the patient is conscious, okay, and oriented is very, very important. For this, we are going to use GCS scale, which I have discussed already in the first class in general examination. Okay, then orientation. This orientation already I have discussed. So time, place, person is very, very important. Okay, then memory. Memory is going to be divided into short-term memory, long-term memory. Okay, long-term memory. Short-term memory with regard to place, person, and time you can ask. Okay, then next is intelligence. This intelligence is also covered in this mini mental state examination. Okay, then next is speech. Okay, speech. Whenever you speak, okay, it is going to be the responsibility of the left hemisphere. Okay, it is going to be the responsibility of the left hemisphere. Okay, left hemisphere means predominantly the patient is going to be a right-handed person, and whenever there is a problem in speech, the patient having problem in the hemisphere is going to develop aphasia. So we have two types of aphasia here. One is going to be Broca's aphasia, the other one is going to be Wernicke's aphasia. Broca's aphasia, okay, Broca's aphasia. Whenever it is going to be a Broca's aphasia, then it is going to be a motor aphasia. Okay, whenever it is Wernicke's aphasia, it is going to be a sensory aphasia. Okay, so when motor aphasia, Wernicke's aphasia, sensory aphasia. That is very, very important. And this is going to be the handedness, which I have already told. Okay, emotions, which can be lesion in the frontal lobe or pseudobulbar palsy. In both the conditions, the emotions are affected. Patient will have emotional ability in the form of cry. Okay, emotional ability in the form of cry. Okay, so that is very important thing. Okay, so here the most important approach whenever you have any case is going to be in the form of a mini mental state examination. Okay, MMSC is very important. Okay, so there are 11 sets of question. Okay, so the 11 sets of question is going to be used for asking or diagnosing in a case of mini mental state examination. Okay, mini mental state examination. So why this is important? Okay, why this is important? Okay, so here whenever a patient is going to come to you, you have check multiple things with this single scale. For that reason, in many places they use this mini mental state examination. Okay, mini mental state examination. Okay, so in if your examiner is going to ask you about this thing, then you're going to tell about mini mental state examination. Okay, so if I have the MMSC, I will add the MMSC here. Okay. So if what is this MMSC? MMSC is mini mental state examination. Okay. So here you're going to have few things. Okay. First is orientation. Okay. Here you are going to ask about orientation to date and orientation to place. Okay. So you are going to ask the patient what is tell me the date. Okay. Tell me the date. Okay. So the patient is going to tell, for example, 8 4 24. Okay, and it is a Monday, Monday, and it is a summer season. Okay, so now for each point you're going to give one score, and the score is going to be 5. Okay, so day, month, year, day, and season. Okay, the next is place. Okay, where are you now? Okay, so if he's going to tell they like address, okay, country, town, building, floor, etc., then it is going to be a score of 5. Okay, then registration, registration. Okay, so tell them to tell them 3 objects. Okay, for example, pen, TV, paper. Okay, and tell them to repeat. Okay, then for each repetition, you're going to give a score of 3. Okay, then next is serial sevens. Serial 7. Okay, serial 7. Okay, is going to be checking the memory. 100 minus 7 minus 7 minus 7 minus 7. Okay, so you're going to give 5 marks here. Okay, now after register, after asking serial 7, then you're going to recall those 3 objects. Okay, when the patient is able to recall those 3 objects, then the score is going to be 3. Okay, then next is naming. Naming. Okay, you show 3 objects. Okay, and ask them what is the name of the object, and score is 2. Okay, repeat a phrase. Okay, repeat a phrase. Okay, you tell them, okay, hi. Okay, how are you? Okay, and tell them to repeat it. Okay, so score is 1. Okay, then verbal commands. Okay, verbal commands. Okay, verbal commands is you tell them to take the paper, okay, fold it into half and put it in the floor. Okay, so if he's going to able to do the sequence of action, then the score is going to be 3. And you can also go for written commands. Okay, where it is written in a paper, close the eyes. Okay, then the score is 1. Okay, then you check for writing. Okay, ask the patient to write a sentence. Then drawing. Okay, drawing, you're going to draw a complex diagram like this. Okay, and the patient should be able to repeat this. Okay, so this is going to be the thing. Okay, இது எல்லாமே உங்களுக்கு கஷ்டமா இருந்துச்சுன்னா then you can remember orientation, recall, registration, attention, command following, language, and executive function. Okay, so you can remember like this also: orientation, registration, recall, attention, language, executive function. Okay, so you can remember like this also: orientation, registration, recall, attention, language, and executive function. Okay, so you can remember like this also: orientation, recall, attention, language, and executive function. Okay, Okay, executive function, executive function. ஸோ இப்படியும் நீங்க செக் பண்ணலாம். ஓகே, ஸோ இது இப்படி பண்ணலாம். சரி, ஸோ வந்து அட்லீஸ்ட் நீங்க சொன்னீங்கன்னா இது வந்து ஒரு added advantage to the your mark. Okay, getting a mark. Okay, so mild cognitive impairment, moderate cognitive impairment, severe cognitive impairment. Okay, so it is going to be 21, 9, okay, 9, 10 to 20. Okay, so நீங்க ஞாபகம் வச்சுக்க வேண்டியது 21. Okay, that is going to be mild, severe na 9, less than 9, அடுத்த moderate 10 to 20. Okay, 10 to 20. இது வந்து ரொம்ப ரொம்ப important. ஓகே, ஸோ இது வந்து ரொம்ப ரொம்ப இம்பார்ட்டண்ட்டான ஒரு விஷயம். மினி மென்டல் ஸ்டேட் எக்ஸாமினேஷன். ஓகே, மினி மென்டல் ஸ்டேட் எக்ஸாமினேஷன். ஓகே, தென் கம்மிங் டு த நெக்ஸ்ட் திங் இஸ் ஆஃப்டர் யுவர் கான்ஷியஸ் லெவல் அசஸ்மெண்ட், ஈவன் தோ திஸ் மெனிஞ்சல் இரிட்டேஷன் சைன்ஸ் ஆர் கம்மிங் லிட்டில் டுவர்ட்ஸ் எண்ட் தான் நீங்க சொல்ல போறீங்க. பட் ஆனாலும் வில் ஸ்டார்ட் ஃப்ரம் ஹியர். ஓகே, ஸோ என்னென்ன பார்க்க போறோம்? ஒன்று வந்து நெக் ஸ்டிஃப்னஸ் பார்க்க போறோம், கர்னிக் சைன் பார்க்க போறோம், ப்ரூசின்ஸ்கி சைன் பார்க்க போறோம். ஓகே, இந்த மூணு சைன் பார்க்க போறோம். ஸோ these signs are very, very important in cases of meningitis, meningoencephalitis, and subarachnoid hemorrhage. Okay, meningitis, meningoencephalitis, subarachnoid hemorrhage. Okay, the subarachnoid hemorrhage, meningoencephalitis, next stiffness pair with the meningismus. Meningismus. Okay, meningismus. Okay, so how we are going to check for neck stiffness? Okay, so whenever you want to check the neck stiffness, support the head of the patient with your fingers at the occiput and ulnar border of your hand against the paraspinal muscles of the neck. Okay, so என்ன பண்ண போறீங்க? உங்களோட பேஷண்ட்க்கு என்ன பண்ண போறீங்க? இந்த ஹெட்டை வந்து ஃபிங்கர்ஸ் கூட சப்போர்ட் பண்ணிட்டு இந்த அல்னார் பார்டர் ஆஃப் த ஹேண்ட் இருக்கு இல்லையா, அகேன்ஸ்ட் த paraspinal muscles of the neckல வச்சுட்டு flex the head gently. Okay, until his chin touches the chest. Okay, if neck stiffness is present, okay, the neck cannot be passively flexed and it may lead to spasm of the neck muscles. Okay, so அங்க வந்து spasm of the neck muscleனால அவங்களால அந்த மாதிரி செய்ய முடியாது. Okay, that is called as neck stiffness. Second is Brudzinski sign. Brudzinski sign. Okay, flexion of knees. Okay, in response to neck flexion. Okay, whenever you flex the necks, the patient leg goes for flexion. This is called as Brudzinski sign. Okay, Brudzinski sign. Okay, Brudzinski sign. Okay, next one is Koenig sign. Okay, so Koenig sign is one where you are going to flex one of the patient legs at the hip and knee joint with the left hand placed over the medial hamstrings. Okay, அதாவது காலில் கை வச்சுட்டு என்ன பண்ண போறீங்க? ஒரு காலை எடுத்து ஃப்ளெக்ஸ் பண்ண போறீங்க. ஃப்ளெக்ஸ் பண்ணிட்டு அதுக்கப்புறமேட்டா என்ன பண்ண போறீங்க? எக்ஸ்டெண்ட் பண்ண போறீங்க. ஓகே, ஃப்ளெக்ஸ் பண்ணிட்டு அண்ட் எக்ஸ்டெண்ட் பண்ண போறீங்க. இப்படி பண்ணும்போது என்ன ஆகும்னா the patient, okay, so there is going to be the extension resisted by spasm in the hamstring muscle. Okay, so the other limb also may go for flexion. Okay, so whenever you flex the leg, okay, and extend, okay, you can feel the spasm at the level of the hamstring muscles. Okay, spasm at the level of the hamstring muscle, which will prevent the extension. Okay, which will prevent this extension. Okay, so this is going to be very, very important Koenig sign, and patient also perceive pain at the hip joint. The hamstrings will be tight. Okay, then whenever the Koenig's is absent, okay, Koenig's is absent, okay, then it means that the neck stiffness is due to local cause. Okay, local cause. Whenever the patient is having Koenig's is negative but neck stiffness is present. Okay, Koenig's absent, neck stiffness present. Okay, then it is due to cervical spine disease, raised intracranial pressure. Raised intracranial pressure. This is responsible for this thing. Okay, so this is very, very important. Okay, then next coming to cranial nerve examination. Okay, cranial nerve examination. Okay, so cranial nerve, the first nerve is olfactory nerve, which has no nucleus and it is a pure sensory nerve. Okay, so whenever you have the olfactory nerve is like this. It passes through the cribriform plate like this, like this. Okay, so it crosses the cribriform plate like this, and it is goes to going to the medial temporal lobe. It goes to the medial temporal lobe and amygdala. Okay, so whenever the patient you're going to examine for the um, sense smell. Okay, so always you check for the patency of the nostrils. Okay, patency of the nostrils. Okay, so you're going to put a spatula, you close one nose, you're going to tell the patient to blow air and other, then you're going to check for the patency. Okay, that is like similar to our Cottle test. Okay, then you check for the shape of the nose for any deformity or deviation. Okay, then ask the patient to close his eyes. Okay, one nostril with a finger, ask him to smell. Okay, different objects. These objects should be known to the person. Okay, so usually in your exam you can take clove. Okay, clove. Okay, elachi, paste, coffee, asafoetida. Okay, so peringayam. Okay, so this you can take. Okay, so loss of sensation of smell is called as anosmia. Okay, anosmia. The anosmia can be usually due to 90% due to local causes. Okay, local causes. Okay, it can also be due to trauma, tumor, and diseases like Parkinson's disease, Alzheimer's disease, or Huntington's disease. Now, neurodegenerative diseases name, you will get loss of smell. Okay, that is called anosmia. So in the definitions, நிச்சயமா கேட்பாங்க. Anosmia is loss of smell or decrease in the sense of smell. Parosmia is pleasant odor being perceived as an unpleasant odor. Parosmia is pleasant to unpleasant. Okay, phantasomia or olfactory hallucination. This is seen in patients whenever the patient has a hallucination in the form of smell. Okay, that is going to be a feature in complex partial seizure or whenever the temporal lobe is getting involved. Okay, temporal lobe is getting involved. Okay, so this is about your uh, olfactory nerve. It's even though it's a simple nerve, small nerve, they can ask you a lot of questions there. Okay, now then next is going to be your second nerve. Okay, second nerve. Then second nerve examination, what they're going to ask is they're going to ask very important things here. Okay, very important things here. Okay, so second nerve, when they usually you finish your ophthalmology just before. So உங்களுக்கு வந்து அது பெரிய விஷயமே கிடையாது. Okay, so imagine this as the eye of a person. Okay, so here we are going to have nasal side coming like this, temporal side coming like this. Okay, temporal side coming like this, nasal side coming like this. Okay, so now what happens? This is what happens here. Okay, so whenever these fibers are going to go like this, these fibers, okay, these fibers is going to go cross like this. These fibers go uncrossed like this. Okay, now whenever there is a lesion, okay, lesion in the optic nerve itself, okay, whenever there is a lesion in the optic nerve itself, okay, then it is going to be optic nerve itself, then it is going to be unilateral blindness. Okay, whenever the lesion is in optic chiasma, what happens? The both the temporal fibers are affected, so it is bitemporal hemianopia. Next is the fibers after optic chiasma are called as optic radiations. Optic radiations. Okay. So whenever there is a optic radiation involvement, they're going to get homonymous hemianopia. So bitemporal means bitemporal. Homonymous hemianopia means okay. Here, whenever the parietal lobe is getting involved, it is going to be whenever the parietal lobe is getting involved, it is going to be inferior quadrantopia. Whenever the temporal lobe is getting involved, it is going to be superior quadrantopia. Okay. Then next is occiput. Okay, occipital cortex. It is going to be the point where the fibers are going to go and enter the occipital cortex. And whenever it is involved, okay, what is going to happen is there is going to be macula sparing homonymous hemianopia. Okay, so this is what given in this diagram also. Okay, so this is going to be unilateral blindness, this is going to be bitemporal hemianopia, this is going to be homonymous hemianopia, this is going to be pie in the sky. Okay, where you get pie in the sky, the pie in the sky. Okay, so it is going to be superior cornucopia temporal lobe, this is inferior cornucopia parietal lobe. Okay, this is called macula sparing homonymous hemianopia when the lesion is in the occipital cortex. Okay, occipital cortex. Okay, any doubt here? Okay. Next is you're going to go for inspection. Okay. Whenever you have any CNS case, okay, second now you have to go for examination where you see for the ptosis. Okay, ptosis. Okay. Whenever it crosses the pupillary area, then it is going to be a significant ptosis. Okay, significant ptosis. Okay, you check for proptosis. The eyeball or the globe is bulging forward. Okay, then you check for pupils. Okay, whenever there is a symmetry affected, asymmetrical pupils, that is called as anisocoria. Anisocoria. Okay, then you check for any squint or nystagmus is present. Okay, so these are very important things. Okay, then next is visual acuity. How you will check for visual acuity? You are going to have a chart called Snellen chart. Okay, this Snellen chart is usually kept at a distance of 6 meter distance. It means that the patient can read from the 6 meter distance. Okay, so the visual acuity is expressed as 6 over. Okay, that at the distance at which the chart is kept. Okay, that is going to be 6 over the number corresponding to the lowest line read. Okay, so the normal vision is 6 by 6. Okay, so it is kept at a distance of 6 meters and the patient is going to able to read this bottom line means his vision is 6 by 6. Okay, if the patient cannot see the top line, okay, then bring the chart little forward by 1 meter. Okay, if the patient is not able to read it at a distance of 1 meter, then you go for counting fingers. When the patient is not able to count the fingers, then you show light, okay, and light perception is present or not, you're going to check for. Okay, so this is going to be your visual acuity. Okay, this is the normal this thing, and if the patient is going to able to read this line, okay, this line, this line, okay, the vision is 6 by 6. The patient is able to read only this sign, okay, then it is going to be, okay, so it is going to be, Okay, so this is going to be the Snellen chart. Okay, the next is field of vision. Okay, the field of vision can be measured by different methods. Okay, like perimetry, etc. Okay, but here we are going to use confrontation method. Okay, confrontation method is you are going to keep the patient sit at a distance of 1 meter. Okay, 1 meter, and you are going to check for the field of vision. Okay, so whenever you check for the field of vision, okay, so the upper uh, part of the eye can move up to 60 degree. Okay, medially up to 60 degree, 100 degree, 75 degree. Okay, based on this, you're going to get a graph like this. You're going to get a graph like this. Whenever you get the graph like this is going to be the field of vision of the person. This is going to be the field of vision. Field of vision. Okay, so this is very very important. Okay, so this you can manage, I think so, because you have finished your um, when you finish your ophthalmology, so you can manage this one is, I think so. The next is pupillary light reflex. Okay, this pupillary light reflex or light reflex can be either done here or in superficial reflex. Okay, so here we have an afferent and an efferent. Okay, the afferent is going to be optic nerve. Okay, optic nerve. Okay, this is going to be the second nerve, and the efferent is going to cause pupillary constriction, which is going to be the third nerve. Okay, which is going to be the third nerve. Okay, so the second nerve is going to be the optic nerve. So where what you're going to do is you're going to show light like this. You're going to show light like this. When you show the light, the optic nerve is going to perceive the sensation, and through the efferent, it is going to cause pupillary constriction. Pupillary constriction. Okay, pupillary constriction. Whenever you do this, you have two types of reflexes. Okay, one is going to be direct light reflex. Another one is indirect or consensual light reflex. Direct light reflex, consensual light reflex. Whenever you have a direct light reflex, okay, absent, okay, consensual light reflex is absent, okay, absent because of the innervation, okay. And whenever you're coming to the other eye where direct reflex is present, and the eye where you are doing consensual reflex is okay, is going to be present. Okay, this is called as Argyll Robertson pupil. Okay, where accommodation reflex is present and pupillary reflex is absent. Okay, so in this case, accommodation reflex is present and pupillary reflex is absent. Okay, accommodation reflex is present and pupillary reflex is absent. Okay, so this is very very important thing. Okay, then coming to the next nerve, which is going to be the oculomotor nerve. Okay, oculomotor nerve, we all know that which is going to be SO4 LR6. Okay, so all the muscles, okay, all the muscles are supplied by third nerve, except for SO4 and LR6. Okay, SO4 and LR6. That is very, very important. Okay, very, very important. Okay, so the organization, if you see, there is going to be parasympathetic uh, fibers located peripherally. Okay, so if you take OPA. Okay, what is this OPA? Okay, if you take the third nerve, the outer fibers supply pupillary fibers. Okay, and the inner fibers supply extraocular muscle. Okay, extraocular muscle. Whenever there is a mass lesion or an aneurysm, okay, what happens is the patient outer fibers and inner fibers both will be affected, and there is going to be loss of extraocular muscle movement, loss of light reflex. But whenever the patient has vasculitis in the form of diabetes, Okay, it is going to affect only the hello. Okay, sorry. Just I got a call. Okay, okay. So this is going to be the thing. Okay, so this vasculitis is seen in diabetic patients, where if you see the patient will have external ophthalmoplegia. Okay, external ophthalmoplegia, but spares the light reflex. It spares the light reflex. Okay, it spares the light reflex. Okay, spares the light reflex. Okay, so this is very important thing. Okay, then whenever you have whenever you have these things, okay, whenever there is a third nerve palsy, the patient will have two important things to be noticed. Okay, the first one is going to be ptosis. Okay, the second one is going to be the first one is going to be ptosis. The second one is going to be the eye. Because of the third nerve palsy, the eye will be deviated down and out. Okay, it is going to be deviated down and out. Okay, so you're going to get a down out eye. Okay, down out eye, down out eye. Okay, it is going to become a down out eye. Okay, so this is very important thing. Okay, because of ptosis, the patient is going to have a down and out eye. Okay, down out eye. Ptosis, down and out eye. Okay, so this is very important in third nerve palsy. Third nerve palsy case இருந்தாலே நீங்க இது வந்து பார்க்கணும். Ptosis இருக்கான்னு பார்க்கணும். Eye வந்து down and out இருக்கான்னு பார்க்கணும். Pupillary reflex இருக்கான்னு பார்க்கணும். Okay, that is very important. Okay, so இதெல்லாம் வந்து very important thing. Okay, so always remember these things. Okay, whenever you have any muscle here. Okay, I'll just draw here. Okay, so if you're going to have the eye. This medial rectus, lateral rectus, okay, lateral rectus, okay. So the medial rectus will cause adduction, okay. Lateral rectus cause abduction, okay. Superior rectus, elevation. Inferior rectus, downward depression, okay. Then superior oblique, okay. Superior oblique, downward and intorsion. Okay, and inferior oblique, upward and extorsion. Upward and extorsion. Okay, upward and extorsion. This is by the inferior oblique. This is by the superior oblique. That's our checkment. Okay, so IUES or DIRSO. Okay, DIRSO or DISO or DISCO. Okay, down and intorsion by superior oblique. Okay, you can remember as DISCO. Okay, DISCO. இது தெரிஞ்சாலே அங்க தெரிஞ்சிடும் என்னது downward intorsion, upward extorsion, inferior oblique. Okay, so this is very important. Okay, very important. Okay, so these are few important things which I want to emphasize in the nerve. Okay, the next is coming to the fifth nerve. Okay, fifth nerve. Okay. Okay, fifth nerve. Whenever you are going to examine the fifth nerve, okay, fifth nerve has three types of nucleus. Okay, one is going to be motor nucleus, okay, which is going to supply all the muscles, okay, of mastication, temporalis muscle, masseter muscle, and pterygoid muscle. Okay, this is the fifth nerve: pterygoid, masseter, and temporalis. Then sensory nucleus. Okay, sensory nucleus is a very large nucleus which is involving the midbrain, pons, and spinal medulla oblongata up to the level of C2 level. Okay, okay, C2 level. It is a very large nucleus. Okay, which is there in the midbrain, pons, and also into the medulla up to the level of C2. Okay, so this is very important. Okay, very important. Okay, whenever you take the motor nucleus, okay, motor nucleus, the motor nucleus supplies, okay, the face, okay, and in the face it is going to supply like this, okay, where it is going to start from the upper part of the nose and goes to the eyelid, and it supplies the whole part of the face here, which is going to be called as V1 or 5-1 division. Okay, 5-1 division. Okay, then next is going to be the mandibular division. Okay, mandibular division, which is going to be involving from the angle of the lips. Okay, it is going to start from the angle of lips and involves to this area. Okay, near the tragus of the ear. Okay, it's going to be like this. Okay, this is called V2 and this is called as V3. Okay, and it spares the angle of mandible, spares the angle of mandible. Okay, so this is going to be V1 segment, this is going to be V2 segment, and this is going to be the V3 segment, and it spares, okay, it spares this part. Okay, that is very important. Okay, so all these parts, okay, since it supplies these parts, you are going to check for touch, temperature, and pain in all these areas. Okay, you're going to check touch, pain, and temperature in all these areas. Okay, and coming to the sensory, this you're going to check, and coming to the motor, you're going to check the muscle bulk. Okay, so temporalis muscle. Okay, temporalis muscle can get atrophy and you can develop a hatchet face, and this hatchet face is seen in myotonia dystrophy. Okay, myotonic dystrophy. Okay, then putting the muscles into action. Okay, so place your hand at the right side of the jaw and ask the patient to the push right. Okay, this is for left pterygoid muscle. Okay, left pterygoid muscle. And so if you want to put the hand here and tell the patient to push towards the left, then you are going to check for the right pterygoid. Right pterygoid. Okay, right pterygoid. Okay, place the hand under the jaw. Okay, and provide resistance and tell the patient to open the mouth. Okay, then you are going to check for the both medial pterygoids. Medial pterygoids. Okay, so this is very, very important. This is what I was discussing, and this is very, very, very important thing. Okay, very, very important thing. Okay, then coming to corneal reflex. Okay, corneal reflex. Corneal reflex is you just touch with the wisp of cortical at the junction between the limbus of cornea and the conjunctiva. Okay, the afferent is by fifth nerve, and the efferent is by the seventh nerve, and the muscle which is going to come into action is going to be orbicularis oculi, and this orbicularis oculi will cause closure of eye, closure of eye. Okay, so this is going to be your corneal reflex. Okay, corneal reflex. Okay, corneal reflex. Okay, then coming to jaw jerk. Okay, jaw jerk, what you're going to do is you are going to tell the patient to open the mouth and you're going to strike with the knee hammer from above. Okay, whenever you strike the knee hammer from above, the patient will open the mouth. Okay, and this is going to be by the third part of your mandibular, third part of your trigeminal nerve, which is going to be mandibular part, and this is going to be if exaggerated. Okay, exaggerated, the patient will open too much. Okay, whenever it is absent, okay, then it is going to be normal, or it is going to be little less significant. But whenever it is going to be exaggerated, then it is going to be human type. Wide opening is going to be human type of palsy, which is exaggerated in human type. So this is called as pseudobulbar palsy. Pseudobulbar palsy. Okay, pseudobulbar palsy. Okay, so human type, fifth nerve involvement, exaggerated pseudobulbar palsy. Okay, so this is seen in pseudobulbar palsy. Okay, so this is about the overall, about all the functions of the fifth nerve. Okay, so fifth nerve ஜார்ஜருக்கு சொல்லாம நீங்க எக்ஸாமுக்கு போகவே கூடாது. ஜார்ஜருக்கு சொல்லாம எக்ஸாமுக்கு போகவே கூடாது. படிக்காம எக்ஸாமுக்கு போகவே கூடாது. Very, very important. Okay, so whenever you strike, it can be absent or just present, then it is normal. If it is exaggerated, okay, then it is going to be bilateral human type of fifth nerve palsy, which is going to be called as pseudobulbar palsy, which is going to be a part of your pseudobulbar palsy. Okay, so this is about your jaw jerk. Okay, so with this we are finishing, we will finish today's class. Okay, because if I take facial now, I require more time for facial now because it is very, very important. Since you have many people have messaged me that college will be there after 7:30, you have to get ready. I am going to stop here. Okay, so we will start from 7th now tomorrow. Okay, and we will discuss the rest of the CNS, and we will try to finish CNS tomorrow. Okay, so this is about your CNS examination, and CNS examination, as you know, it is very, very important for your exam. Okay, so thank you all. Tomorrow again we will meet at 6 or 6:30 in the morning. Okay, I will message you the timing. Okay, 6 or 6:30, so that we can go for 1.5 hours possibly. Okay, since your exam is little late, we have enough time, I think. So we will finish everything, nothing will be left behind. Okay, if you have any individual topics need it, you can message me. Okay. Thank you all.